For today's show, and my guests are Margie Ware, Elder Services Care Transition Team Leader, and Dorothy Phillips with the Berkshire Visiting Nurse Association. She's the Care Transition Nurse Practitioner. And as you might guess, our topic has something to do with care transition from hospital to home. And this is a collaboration between Berkshire Medical Center, the Berkshire Visiting Nurse Association, and Elder Services of Berkshire County. Welcome.
Thank you.
Thank you.
So, a little bit of a fancy name, a little intimidating maybe. Margie, would you like to tell us what the basic goal of the program is?
The basic goal is to prevent rehospitalizations, especially within 30 days of hospitalization, but really in the first year after somebody's in the hospital. There are many statistics that show that one of the cost drivers of Medicare is people who they leave the hospital and they don't understand what their medication regime is, or they don't follow up and go to the doctor when they're supposed to, or they don't know what signs to look for, and they end right back in, sometimes within 3 to 5 days of their discharge. So we're trying to kind of push those dates out and give people some basic coaching and information so that they can be more in control of their own lives.
Dorothy, could you tell us on the hospital end of things, what happens when, I'm assuming that because you mentioned Medicare, that this is for Medicare
That's right.
people, what happens when a Medicare eligible person winds up at Berkshire Medical Center?
Well, Margie and I work with a very experienced nurse, Claire Berkery, who does the hospital part of the screening patients for who is eligible for the program and who might benefit from the program. So the hospital every day prepares a list of the people who are Medicare who've been admitted in the previous 24 hours, and then Claire goes through their records and tries to find people who would be most likely to benefit from the program. Mostly we're trying to identify people who are at very high risk for rehospitalization. There are some differences between Margie's end of the program and my end of the program, but often readmissions are preventable. So she's looking for people who might benefit from that kind of intervention.
So she's looking at every Medicare eligible person to see whether or not they're
First of all,
eligible?
If someone doesn't qualify for the program unless they've been previously admitted to the hospital. So by coming back within the previous year, they've already shown that they're at high risk for readmission.
So I think before we even get into any details or whatever, one of the huge questions that a caregiver or a person at home or someone who winds up in the hospital always asks is, what's it going to cost me?
Absolutely nothing. This is a Medicare benefit. It is to Medicare's benefit for you to receive this kind of coaching and attention in the hospital and at home for the next 30 days. So there is no cost, and what we're hoping is that through getting correct information and having just a little more support, and I'm glad you mentioned caregivers, because that the caregivers are so much part of the team, and sometimes if the person who's been discharged isn't quite up to dealing with a lot of complex information, the caregiver, we give people a personal health record to write things down in, and the caregiver can be in charge of utilizing that personal health record and keeping track of doctor's appointments and medication changes and all that kind of thing.
Just if I could add to what Margie said, what the program we have, not only is it free, but it doesn't replace any other care that someone has. So it's an addition to their usual care with their usual providers. And there is nothing in the program that would prevent someone from being readmitted to the hospital if it was necessary. We hope to prevent avoidable readmissions, but not all readmissions. Part of what we need to do is make sure people know when it is appropriate to call their healthcare providers or to come into the hospital so that their health isn't in danger.
Do I need to know about this program before if I wind up in the hospital, do I need to know about it, or does it just happen?
It happens. That's what Claire does, is she's looking at the list of people who have been hospitalized once or twice before in the last year. Then she meets the person and describes the program to them, and then a coach who's on duty at the hospital, or Dorothy's program, it's a different model. It's called the Naylor model. Her program is looking at people who have much more complex needs. Ours is a coaching model, so it's very much about empowering the individual. So Claire's coming in and explaining it, and then the coach comes in and introduces him or herself and talks about what our goals are, gives them the personal health record, and we ask them if they'd like to participate. We make sure that they understand that it is free, that it is part of their Medicare benefit, it is part of their discharge plan, and that we're just trying to be there as an extra set of eyes and ears for questions. Many times, for example, somebody might enter the hospital with one list of medications, and while they're there, the list changes. And then they go home, well, am I supposed to go back to what I was taking before? Am I supposed to take this list or some combination, permutation of the two combined? And it's those basic kinds of questions. If I gain 4 pounds in the first 2 days after I get home, should I be worried about that, or is that normal because I was on hospital food, or whatever the question is? And so we try to go from simple things to levels of complexity where if X happens, absolutely you call the doctor. If Y happens, absolutely you go to the ED.
When a person leaves the hospital, that last day, there's usually just a slew of people who come in their room, and they tell them this and that, and this instruction and that instruction. So now it sounds like you've added one more person to the list, or maybe two. If you wind up, is that possible? Would you wind up with both a nurse practitioner and a...
When Claire reviews the patients, the people who are hospitalized, she will assign them to either the coaching model or to the model that I follow, which is called the Naylor model, from a nurse researcher at University of Pennsylvania. And you're right that it is another layer to come in, and you're also absolutely right that that's a very confusing time. So ideally what we're hoping to do is to simplify that process by providing a constant presence to transition from the hospital, where you're meeting all these people, to continue that relationship when they go home. In the Naylor model, the relationship is also continued with their medical providers. So under the Naylor model, when I'm involved with someone in the program, I meet them in the hospital, I see them in their homes, but then I often go with them to their follow-up medical appointments so that the information can be transmitted accurately over all of the different levels of care. But you're right, it's a complex process. There are a lot of things that can go wrong. Our healthcare system can be very fragmented. So that's why Medicare is looking at some ways to try to tie the system together a little more tightly to prevent bad things from happening.
Would it be fair to say that when I'm at the hospital and I gather I have to say yes to agreeing to these services, that I agree to the services, that I'm either going to be assigned a coach or a nurse practitioner?
That's right.
One or the other? And all right, and from what you just said, that person, their involvement with me doesn't end when I leave the hospital.
It starts when you leave the hospital, and it goes for a period of approximately 30 days. There are some situations where it might go a little bit beyond 30 days, but the metric, as they say in the business, that they're focusing on is whether the patients who receive these kinds of interventions stay out of the hospital for at least 30 days. And if they do, that's considered to be a successful intervention. And very frankly, even if somebody came back within 30 days, it might be that for people who have that set of symptoms, that the average rehospitalization has been 5 days, and we kept them out for 25 days. That's still a success. because we've intervened and, you know, kept things a little more stable. And sometimes it's not possible to avoid rehospitalization, especially the people that Dorothy sees have a much greater level of complexity and fragility than the people with the coaching model. The coaching model, we're targeting people who are themselves, you know, intellectually able to absorb the information and act on their own behalf.
Do I get a choice as to whether I get a coach or a nurse practitioner?
That's a medical decision, right?
Yeah, that's a decision that Claire makes. She's very, very experienced, and I think what happens is that when someone goes home, it's not that there's a strict dividing line. There may be a lot of different services they go home with. They may go home with visiting nurses. If they go home with visiting nurses, they may still have a coach, or I may still be involved. So it's not like there's a big gap in the middle that people can fall through. There's sort of a continuum of services that people might qualify for. At this point, the program is still quite small, so we can't quite take care of everyone who would qualify, although we hope that the program will grow in the future.
Who decides, and maybe it's variable, the definition of at risk for this particular program?
Actually, there's a number of criteria that are used in lots of different settings to define who's at risk. We use criteria. Claire applies criteria to decide which people are more likely to be able to benefit from the coaching model versus the model I have. In the coaching model, you have to be able to really, you have to have a higher level of independence because you really are assuming more responsibility for your own care. I also may work with people who are quite able to understand their medications and quite able to understand the complexity of their care, but they may have a number of different medical conditions that are unstable and that might change at any time. So if there are 3 or 4 different problems occurring at the same time, then that might put that person in a higher level of risk than someone who maybe was dealing with a smaller number of medical problems.
What if I don't know that I'm at risk? What if...
You certainly can refuse participation in the program. This is not a compulsory program at all. People have the right to refuse any of the care that we're offering. We just try to be persuasive, and we have different ways of looking at it. I know in the Naylor model, sometimes we describe it as having a nurse in the family. Everyone who has a nurse in the family can relate to how much simpler it is when you go to a doctor's appointment, when you have someone with you who can kind of translate the information. So we try to make it as supportive as it can be.
I think the other point about being at risk is that initial conversation in the hospital, sometimes when you start talking to the person, you realize that they're not really quite sure why they ended up in the hospital. Or they've gone to the hospital enough, it's like, oh, well, you know, every once in a while I just end up in the hospital. And so when you have more conversation, then you start saying, well, we had one person who turns out she always ended up in the hospital after her children came to visit. And one of the underlying things ended up being that the children lived out of town. And when they came, she wanted to make sure that they thought everything was okay. So she wouldn't use a wheelchair, she wouldn't use a cane, she wouldn't use a walker. She would exhaust herself. The next thing you know, she'd be in the hospital. So the coach started that conversation with her about, so the next time your family comes to visit, what are you going to do? And she started saying, yeah, I'm going to say if we go to the mall, get me a wheelchair or bring one up, or let's rent one, or maybe I should just have one at home. And that's a kind of a basic thing, but it's making those connections between, you know, the stimulus and the response.
I get a little, I'm not going to say confused, but perhaps a little on the anxiety side when I hear about a Naylor model and a coaching model and whatever, and if I were in the hospital and I was being offered something, I'd say, well, you're making my head spin. What happens to the person?
The person isn't given sort of an intellectual discussion about different ways you can coach people. When Claire is talking to the person, she's already decided which model of intervention they're appropriate for. So she starts off the conversation narrowing that discussion to we have a coaching program, and talking about that again in sort of a positive, user-friendly way, or talking about that we have a nurse practitioner who could actually go with you to your next doctor's appointment and who could visit you at home. So a lot of the kind of details in the background aren't really known. I mean, if people have questions, we're more than happy to ask questions. But you're right, sometimes too much information is not